and welcome to Humanist Canada's monthly webinar series. I'm Anna Popovich, Program Director at Humanist Canada, and your host this afternoon. This webinar will be 60 minutes in length with questions with a Q&A period allotted with a Q&A period at the end of the presentation. Apologies for that. If you have a question and would like to ask it directly, please raise your hand at the bottom of the screen. You can also submit your question or comment with the Q&A tool at the bottom of your screen anytime throughout the presentation. And this webinar will be recorded. Our guest today is Jill Doctoroff, the Executive Director of the National Abortion Federation of Canada and the Canadian Director at the National Abortion Federation. The bulk of Jill's career has been in the non-for-profit sector, focusing on sexual and reproductive health and rights. She briefly worked in the public sector as a public health program manager with Vancouver Coastal Health Authority. Prior to that, Jill was the executive director of the Elizabeth Bagshaw Clinic, a community-based facility that provides abortion care. She has also worked as the executive director at the Asian Society for the Intervention of AIDS and Planned Parenthood Ottawa, focusing on education, information outreach, and pregnancy option support counseling. Jill has international work experience both as a regional program officer with Canadian Crossroads International, focusing on Latin America, and with a national women's organization in El Salvador. She has served on the boards of directors with Canadians for Choice and Options for Sexual Health. And she is currently on the executive of 100 Women Who Care Vancouver, a group that harnesses the power of community. And our very timely topic today is abortion care in Canada. And Jill, thank you so much for joining us. It's a pleasure to have you, and over to you.
Thank you so much for the introduction, and thank you to the Humanist Canada for having me here today. Hoping that you can see my screen. I'm going to be talking a little bit about abortion care in Canada, and as you said, my name is Jill, and I use she and her for my pronouns. I'd like to acknowledge that the NAF Canada office is located on the traditional and unceded territories of the Algonquin-speaking peoples, made up of the Esquimalt and Fungis First Nations. I think it's important to reflect on whose land we are on and who's been caring for it for time immemorial, especially when we're talking about healthcare, and we know the complicated relationship that we've had with Indigenous folks and not great treatment, especially around sexual and reproductive health, with things like forced sterilization and things that continue to this day. So it's important to think about that. I'm going to move on to a little bit about what we're talking about. I'm going to just give a brief overview of the organization I work for, a bit of history of abortion care in Canada so that we can understand the current context, some of the challenges related to abortion care, and some of the supports, what's happening in the United States, and then finish off with what we're doing, what we can be doing. But first, I'm going to talk a little bit about language. You're going to hear me talking about people can get pregnant, people with uteruses. Also, though, you're sometimes going to hear me use the word woman or women. And I just wanted to make sure that people recognize that I understand and our organization understands that not all people with the capacity to get pregnant identify as women, and that we try to use as much gender inclusive language as possible. But sometimes we're also using women specifically to talk about the gendered nature of the care that abortion care is, and how it has a long history with oppressing women in a variety of ways, and just gender discrimination. And I also want to just talk about two other terms that I'm going to use. And one term is medication abortion, and some of you might have heard about it as medical abortion or abortion with pills. What I'm referring to is medication abortion, the taking of drugs to stop a pregnancy. The other term is procedural abortion. Some folks might have heard surgical abortion, aspiration abortion, D&E, D&C. And what I'm referring to as procedural abortion is any intervention with instruments that are entered into the uterus, into the cervix, into the uterus, and empties the contents of the uterus. And when I say any instrument, I'm talking about in a medical healthcare system context. So NAF Canada, we promote, enhance, and ensure access to quality abortion care. We formed in Canada in 2007. We're not a membership-based organization. We're a registered charity, and we're able to take donations and issue charitable donation receipts. And we have 4 main program areas. I'm going to talk most about education and training, as well as supporting pregnant people who need to access abortion care, but we also do some outreach and advocacy, and we also engage in research. The training and education, we do a lot of training for existing abortion providers. We have a conference every spring for 1 day, and then we have another one in the fall for usually 2 days, and that's for folks who are involved in abortion care. And then since medication abortion became available just over 5 years ago in Canada, we identified a gap in training for primary care professionals. So we've been doing that, and since the advent of since the pandemic, we've had to be nimble and change what we're doing. And so we've developed a web-based course that covers all of the elements of medication abortion and how to incorporate it into a practice so that you leave the course feeling confident that you have the skills that you need, and not just the knowledge around what the drugs are and what they're supposed to do, but the whole picture, so that folks can feel comfortable then adding this to their practice. The other program I want to just talk briefly about is our patient assistance, which is called the Dr. Morgentaler Patient Assistance Fund and Information Service. We have a hotline that pregnant people can call to access resources, to ask about potential funding, and we really do traditionally have supported people with donations we receive for folks who have financial barriers. So that could be someone who's uninsured and needs to pay for a procedure fee or needs to pay for the medication, or it might be somebody that is insured but can't afford the cost of travel from their home community to wherever they need to go to access abortion care. So as I said, this has mainly been funded through the generous donations of Canadians. However, in February of this year, we received a time-sensitive grant from Health Canada that really helps with the travel and accommodation components of the support. And we still use the donations that we received to help people who are uninsured. So that's just my overview of our organization. And now I'm going to give you a little bit of information about abortion care. So it was criminalized in 1869. And then 100 years later, it was partially decriminalized. So in the criminal code, it was partially decriminalized by indicating that hospitals had the option of forming a therapeutic abortion committee. And if that committee said that a pregnancy would likely endanger a woman's life or health, then she could get an abortion. Hospitals weren't required to set up therapeutic abortion committees or TACs. And if they did set them up, they needed 3 physicians to sit on the TAC, and then a different 4th physician would be the one who is providing the abortion. And there was no provision for abortion care outside of hospitals and community settings. So in the 1970s, most famously, we saw Dr. Morgentaler in Montreal provide abortion care in his office. And he was arrested, he was tried, and he was acquitted 3 times by a jury of his peers. And each time that he was tried, his defense was that he was providing abortion care out of necessity, and that his reasoning was that his medical responsibility to the health and the well-being of his patient made it impossible for him to obey the law. So as I mentioned, acquitted 3 times. One of those times, though, the judge overruled the jury's decision and found him guilty, and he served almost a year in prison. When he came out of prison, the Quebec government said, we're not going to be prosecuting healthcare professionals providing abortion care in community settings anymore. So around 1982, when Canada got the Charter of Rights and Freedoms, which is going to come in to play in a few moments from now, was also right around the same time when Dr. Morgentaler went to Toronto and with some other physicians opened a clinic in a community setting there. Just like in Montreal, they were promptly arrested, tried, and acquitted. And the acquittal was appealed by the province of Ontario, and a retrial was ordered. Dr. Morgentaler appealed this decision, and he actually changed what he used as his defense. So what he actually used as his defense is that the abortion law was unconstitutional because it violated our Charter of Rights and Freedoms for life, liberty, and the security of the person. And so in 1988, actually January 28th, the Supreme Court of Canada ruled and agreed with Dr. Morgentaler that it did violate the Charter of Rights and Freedoms, and so that's when abortion was decriminalized. Shortly thereafter, the government at the time introduced a new bill that would have criminalized abortion again, if not, there was no provision, if it was not found that there was a danger to the woman's health or life, the pregnant person's health or life. And it passed through the House of Commons, and it passed into the Senate. And something that's really unusual for Canada is it was actually defeated by a tie vote in the Senate. And there haven't been any other wholesale or large bills that have been introduced since then to ban abortion altogether. We did see after that some court challenges where there was a challenge whether the father of a pregnancy could have some impact on abortion, stopping it from happening, as well as whether the fetus had any rights, and those were both deemed to not be the case. What we did see in the 2000s, and we have been seeing since then, is some private member bills. And these are bills that would really have the purpose of restricting abortion. So some of them were really upfront about it. Like there was a bill that was introduced that would have banned abortion after 20 weeks. And then there are others that were less upfront about it, like an Unborn Victims of Violence Act, when they wanted to have an additional criminal penalty for somebody who was found to injure a pregnant person as well as the fetus during that act of violence. And so none of these have actually gone farther and become laws, but they're bills that get introduced frequently. And many people think that they're a way to try to restrict some access to abortion. In 2015, a really important thing happened in Canada. We were the last higher resource country in the world to get medication abortion using the gold standard, which is a combination of two medications, mifepristone and misoprostol. And in 2015, it was approved by Health Canada. And by 2017, in January of that year, it was available to be prescribed and bought under the name of mifegymiso to pregnant people. And so in the 5 years since that's been available, looking at where we are today and what we look at is access to abortion care still remains a concern. That brings us to the here and the now. And so abortion care is healthcare, and it's regulated like healthcare. So there are colleges of physicians and surgeons in different provinces that provide some of the regulation and oversight. There's hospitals, there's territorial, province, and provincial health authorities or health bodies. They're all regulating abortion care. The cost to see a healthcare professional for an abortion is covered under all provinces and territories' health insurance plan. I'm in British Columbia. It's covered under MSP. OHIP in Ontario covers it. All the provinces and territories do. And for the most part, it's a self-referral procedure, meaning that an individual doesn't need to get a referral like we do to see a specialist. They can often just call up an abortion clinic and make their own appointment. There are some situations where a referral is required, and that's often just due to how that specific provider or how that specific site is able to manage the need for the service in their community. We see abortions happening in community-based clinics, independent facilities throughout the country, as well as in hospital programs, clinics in a hospital. And then there are some, well, actually many, physicians in different parts of the country that have some operating room time, and they use that operating room time to provide abortion care. So it might be hard to know who to call in that community, but there are other individuals like physicians who might know how to get in touch with a physician providing abortion care through some of their hospital time. As I mentioned, medication abortion became available just over 5 years ago. And so the cost of the medication at the pharmacy is between about $350 and $400. So this, when it was first available, introduced a real challenge because procedural abortion was completely covered in our healthcare system, and the visit to a healthcare provider for medication abortion is completely covered. But really, the actual medication was a huge barrier. So in the first, I would say about 2 or 3 years, all provinces and territories and federal programs, except for none of it, now cover the cost of medications for folks who are in their province or territory with health insurance. One thing that we've probably heard a fair amount about is Planned Parenthood in the United States providing abortion care. And the history of Planned Parenthood here in Canada is a little bit different, and they haven't provided all across the country, they haven't consistently provided clinical care. But in the last couple of years, we've seen the ones that have provided clinical care are also now offering medication abortion with mifepristone and misoprostol. And some of folks might not be necessarily aware of the Planned Parenthoods because a lot of them have changed their names over the course of the last 10 or 20 years. So this is a map of Canada. We're all familiar with it. And just sort of as I mentioned, so abortion care is healthcare. And so just like healthcare is a little bit different in different provinces or territories, so is abortion care. So if we look at the earlier end of the spectrum, Nunavut and Prince Edward Island provide abortion care till around 13 weeks, although I've heard PEI is looking at increasing that. And then we look at later abortion care, some saying about 20 weeks and above. There are 5 provinces and territories that provide that care. So there's quite a difference in parts of the country. Some of you might have heard of an access zone or a bubble zone. In 1995, British Columbia got a Safe Access to Abortion Act. And what that was legislation that prohibited, among other things, protest activity or interference within a specific geographic region of an abortion facility. And that was the first province to get it. Some other locations had some injunctions, but no other provinces had that kind of legislation. And then fast forward 20 years, or about 5 or 6 years ago, we see a whole spat. So we see an additional 5 provinces that have introduced this kind of legislation. And one of the reasons that it's so important, what it means is that people can access healthcare and or their place of employment with respect and dignity and aren't being interfered with by people who don't want them to exercise their rights to access healthcare. I'm going to talk now about some of the challenges. There's a lot. I'm not going to go into all of them. Some will go into more details than others. So the main challenges that I'm going to be talking about are myths, access to accurate and reliable information, stigma, and then just access overall. So there's a lot of myths surrounding abortion care. I'm going to touch mainly on the 3 that I think I hear about the most often, and those are abortion as birth control, psychological impacts, and a link between abortion and breast cancer. There's lots of other myths that we could talk about. I often hear a lot about only teenagers are accessing abortion care. And if we look at some data that's available from 2020 about abortion in Canada, we see that 2% of people who accessed abortion care were 17 and under, whereas 41% were 30 and over. So that's just a quick demonstration of a myth that we often hear about, but I won't go into much detail about. So when we talk about birth control or abortion as birth control, we sometimes hear people say things like, I support a person's right to have an abortion as long as they don't use it for birth control. And what does that really mean? Let's unpack that a bit. We know that worldwide, half of the people who access abortion care are doing it for their first time. It's their first abortion. We also know that for people who have the ability to get pregnant, they're fertile for about 30 years, and no form of birth control is 100% effective. We know that people who have uteruses usually have 1 or 2 unplanned pregnancies in their lifetime. Some of those end in a live birth, and some of those end in an abortion. And the other thing that we know is that many of the people who have accessed abortion care also use contraception in the 12 months before they access their abortion care. So that just really shows that this is a myth. It's not supported by data. Really is it's really value laden. It implies that there are some people who deserve abortion care and some people who don't deserve it. We know that abortion care doesn't cause any lasting impacts on someone's health or on their fertility. Some people use contraceptives or don't want to, and some people can't. And we know abortion is safe and it's effective. So this myth is really predicated on abortion stigma. Every reason to have an abortion is a valid reason. As I said, it doesn't cause any impacts to one's health. It is, however, expensive to the healthcare system, and it can be time consuming for the individual. So some other options can be more convenient for people, but having more than 1 abortion is totally fine and it's totally normal. The other myth I hear a lot is that if you access abortion care, you're going to be psychologically damaged for life. And I've heard this term floated around called post-abortion stress syndrome, or PASS. And there's no evidence anywhere that this is actually a syndrome or something that exists. It's not in the Diagnostic and Statistical Manual of Mental Disorders. All major psychological organizations have denounced it as fabricated. And from studies, we know that the best indicator of someone's mental health after abortion care is their mental health before abortion care. And also studies show that people have a range of emotions related to abortion care. They might feel sadness, they might feel guilt, they might feel relief, they might feel happiness, or maybe numb. But when they're followed over years, 99% of them say that they know that they made the best decision for themselves, the right decision for themselves when they chose abortion. The last myth that I feel like comes up every couple of years is people who have abortions have a higher rate or higher risk of breast cancer. And there was a great study done in 1997 by some Danish researchers that was able to look at actual data from 1.5 million people who accessed abortion care. So they looked at the registry for abortion care and they looked at the registry for breast cancer, and they found that there was actually no link between that. And those kinds of studies have a lot of value because they're not relying on an individual's recall. They're just looking at what happened and what didn't happen. So just like with mental health, all major cancer organizations have said there's no link between abortion care and between breast cancer, and the World Health Organization also agrees with that. So another kind of challenge related to abortion care is accurate or inaccurate information. And there's lots of different sources of inaccurate information. So one of them can be anti-choice healthcare professionals who don't want their patients to access abortion care and don't want to give them the information that they need to make the decisions that they know are right for themselves. Another source of inaccurate information can be crisis pregnancy centers, which are sometimes called CPCs. I don't know how familiar folks are with them, but I'll tell you a little bit about them. Sometimes maybe you've seen an ad on public transit or in a bus station or a bus shelter will maybe say something like pregnant, need help, and gives the number to call. And they tend to support parenting and adoption as the two options from a pregnancy and not abortion. However, they don't tend to be really upfront about that. And if they are talking about abortion care, it can be difficult to know that they're not going to be providing accurate information. In the last couple of years, the websites for CPCs have gotten a lot more savvy, and they actually look very pro-woman or pro-choice or pro-support, and it can be hard to dig into them and really find out what they're offering. Sometimes you'll see information about PATH, which can be a good indication. And also, I guess one thing to note too is one of the reasons it's a big issue is there's more crisis pregnancy centers in Canada than there are abortion facilities. Another thing that contributes to inaccurate information is this concept of a medication abortion pill reversal. And it's got a lot more traction in the United States, but I've been hearing more and more about it in Canada in the last couple of years. And there was an anti-choice healthcare professional who said that that he did a study, and it showed that after people took the first drug of the two-drug combination, the mifepristone, he was successfully able to reverse the abortion and people could continue their pregnancy. And so this is dangerous for a couple of reasons. One is a group of researchers decided they were going to try to replicate the study that was done, and they were going to use sound research principles, and they had to stop their research very early because what they were finding is that the actual pregnant people were in danger because they were hemorrhaging more than had anticipated when they didn't provide the second set of drugs associated with medication abortion. And then the other reason I think it can be dangerous is it really gives that idea that people who are deciding to have an abortion haven't thought about it, and it's something that they might just change their mind, when in reality, that's not supported by any evidence or research. And then I put the internet in. I was sort of humming and hawing whether I should or not, because I think for so many things, the internet can be a great source of information as well as not a great source, and that we just have to be really savvy and look at where the source of the information is. And I think part of the reason I put it in is because during the pandemic, it was such a source that people used, and some of the information was valuable and a lot of it wasn't. The last source of inaccurate information I want to talk about is health data that comes from Canada, and it comes to the Canadian Institute for Health Information, which is also sometimes referred to as CIHI. And it's an organization that collects data on a whole range of health topics in Canada, and specifically related to abortion care and probably other care, it's mandatory for hospitals to report, and for abortion care, it's voluntary for clinic, and it's more limited. It's limited in the scope of the information that's received, but it's also limited to the abortion providers or the abortion clinics that CIHI is aware of. With all of those caveats, it is the most comprehensive source of data that we have in Canada today. These are the stats. So just this past spring, the 2020 data was released. And so we'll look here, and you look at from 2011 to 2014, there's a pretty big discrepancy from the initial totals to the revised totals. And that's because for many years, the data that CIHI was able to collect was really grossly underreported, and it was known to be an issue, and it wasn't until 2015 that CIHI was able to come up with a way to really get more reliable data. I highlight that because I think we're going in that same direction, and I talked to the folks at CIHI, and they are aware, and they're just looking for other mechanisms to gather the data. And the reason I'm mentioning this is because there is no mechanism right now for CIHI to gather data for abortions, particularly medication abortions, happening in a primary care setting. So there's sort of 2 years that I think are really noteworthy. And I'm just going to say straight out, like, I'm speculating. I don't know. I don't have the data. But if you look at the about 10% drop of reported abortions from 2017 to 2018, that really lines up really well when medication abortion was, became available and was getting more of an uptake among primary care providers. And then you see from 2019 to 2020, another drop of about 10% as well. And again, speculating, but that also corresponds with the pandemic and more people looking for alternatives to interacting with the healthcare system. So I'm imagining that perhaps more primary care people were offering it to their patients to limit the amount of contact individuals have with the healthcare system. Pure speculation, I don't know for sure, but I have been working in abortion care for about 15 years, and I'm not hearing that people are seeing a ginormous decrease in demand. I also wanted to draw your attention to the 2020 location data. So you can see from the first column of numbers that less than 1/3 of abortions that were reported in 2020 were hospital-based. And I just bring that to your attention because that's where we get the richer data when we find out information about an individual's previous pregnancy history or a complication or the kind of abortion they had. And so we'll see here that in 2020, just about 10% of reported abortions from hospitals were medication abortion. And that is a big increase from 2016 when we didn't have the gold standard of drugs for medication abortion. It was 3.7%, and we've seen it increasing steadily. But I do work with facilities across the country, and it's not uncommon to hear that maybe 40% of individuals are using medication for their abortion. So that's the big part about data that I wanted to talk about, or information and challenges around abortion care. And now I want to talk a little bit about stigma. I'm sure we're all aware of stigma and what it is, but it's often a vicious cycle. Stigma can be created by concealing something. So in this case, concealing accessing abortion care, providing abortion care, and it continues to create that circle of silence of people not really knowing necessarily that they know somebody who has abortion care, who has access to abortion care, or who is involved in abortion care, and it really perpetuates that stigma. That being said, I also acknowledge that it's an individual's choice whether they want to talk about their abortion or their abortion care work or not. But I think due to the stigma surrounding abortion care, many people underestimate how common it is. We know that one in 3 or 1 in 4 people who can get pregnant will have an abortion in their reproductive years. And also abortion care is a really stigmatized form of healthcare in general. Most medical schools, most nurse practitioner programs, most midwifery programs don't provide any or enough detailed information about abortion care. And I think if you look at the number of people who need abortion care and interact with the healthcare system, it would really be beneficial to the system overall. If people, I'm not saying that all healthcare professionals need to provide abortion care, but they need to be able to know what it is and be able to talk about it in a way that helps the person who's looking for information make a decision. Now I want to go back to access. And I know I talked about this a little bit early on, but I just wanted to highlight that not just from province to province or territory is there a discrepancy, and access can be an issue. So for example, in the 4 Atlantic provinces, abortion care is only available to 16 weeks. So that means anybody with a pregnancy beyond that has to leave their home community at their own expense and travel somewhere else in Canada to access abortion care. But we're also seeing that within provinces. The vast majority of abortion facilities are located about 100 to 150 kilometers from the Canada-US border, which really corresponds with all of the major urban city centers. There's a discrepancy between provinces and territories, and also within them. Another access thing, I'm going to pick on New Brunswick. So New Brunswick has always had restrictions that no other province or territory has had. So since abortion care was decriminalized in 2015, the government of New Brunswick only paid for abortions through their healthcare fee-for-service model that we all live in. If the abortion was performed by an obstetrician gynecologist, that there were 2 referrals from other healthcare professionals that deemed the abortion to be medically necessary, and that abortion was performed in a hospital. So in 2015, there was a change, and 2 of those 3 restrictions were let go. and still New Brunswick is only providing abortion care for abortions that are performed in a hospital setting. There are 3 hospitals in 2 separate cities that provide abortion care in New Brunswick. There has for a long, long time been a clinic in Fredericton, which is a town that doesn't have hospital abortion care, that has never been able to bill the government for the services of the physician because it's not a hospital. So that's a huge access for folks living in New Brunswick. And just a little like potential thing that might make an impact in the future is that the Canadian Civil Liberties Association has last year launched a lawsuit against the province of New Brunswick over this regulation because it's restricting a pregnant person's access to abortion care that doesn't have any relationship to something that's medically necessary or medically justified. So hopefully we'll see that work its way through the justice system and there'll be some changes there. The other thing I want to talk about specifically around access is later abortion care. So I'm just going to start off with the overall statement that it's really difficult to access an abortion in Canada past 24 weeks. But even past 20 weeks, it can be very challenging, and there's a lot of different reasons. So if something's not available, it's really hard for a provider to be trained on it and to maintain their level of competency. So that's one issue. Unlike in the United States, the vast majority of abortion care over 20 weeks is in a hospital setting. So in order for a program to move forward in a hospital setting, all kinds of institutional support is needed, not just one group or another group, but administration support, the different departments that could be involved, sometimes ethics, sometimes the funding body that's attached to it or the foundation that's attached to it. And then another thing that also can be a barrier to abortion care over 20 weeks are, as I said, abortion care is healthcare and healthcare is regulated. So for example, in Alberta, the abortion community clinics are regulated by the College of Physicians and Surgeons of Alberta, and they stipulate that abortion care can't be provided in a community setting after 20 weeks. In British Columbia, it's 17 weeks, so it really changes. So often people who have pregnancies beyond 24 weeks are traveling to the United States for support, to access abortion care. I was jumping ahead of myself when I said support because I wanted to talk about some of the supports now that we've talked about some of the challenges. So there's lots of great supports around information, but you have to know where to find them. I'm not going to toot our own horn, but obviously we have a website, NAF Canada, that we think has got lots of valuable information. There are 2 other national pro-choice organizations in Canada that focus around abortion care. Action Canada for Sexual Health and Rights has a great website with lots of information, and so does the Abortion Rights Coalition in Canada. And then I talked about the course that we developed for helping with inaccurate information among healthcare professionals. So some of the stigma busting supports that I think are great. A lot of them are web-based, which is so helpful because what would we do without our phones, right? Without our devices. So one of them is You Know Me, and that's a hashtag that was started in 2019 by abortion rights advocates. And that was started in the United States. And it was really to counter that idea that people thought they didn't know people who accessed abortion. So it was a hashtag where people could tell their story or just say, their name or whatever they wanted. Another one is called Shout Your Abortion, and that's a network of individuals who want to talk about their abortion on their own terms, and they've created a safe space to do that. Again, people can tell their own stories, people can read other people's stories. And then there's the 1 in 3 campaign. Again, that relates to 1 in 3 people who can get pregnant will have an abortion during their reproductive years. And that's a movement of storytelling, grassroots organizing, and leadership development, as well as some advocacy. So those are some great ways. And then there's a really great Canadian source that I wanted to talk about, and it's called One Kind Word, and it's a book, Women Sharing Their Abortion Stories. So it was published in 2014, and it's personal stories from over 30 people who have either accessed abortion care who are working in abortion care, and it really just brings home to individuals who need to recognize it that we all know people involved in abortion care or who have accessed abortion. Some access supports I had mentioned, again, our course, not going to talk about, I already did. But one of the really neat things that happened when medication abortion became available in Canada is that it took it outside of the scope of only physicians. So traditionally, family practice physicians and obstetrician gynecologists were the ones who were providing abortion care. But with medication abortion, it's really broadened the scope where nurse practitioners can offer it, a wide range of physicians. And then really exciting late breaking news, just this week, Quebec was the first province to acknowledge that medication abortion is within the scope of midwives' independent practice, which is amazing and so exciting. And before that announcement, and still happening now, there have been some different programs. So there's different groups of midwives in Ontario that I'm aware of who are providing a medication abortion under a collaboration and a medical directive with physicians or nurse practitioners. So that scope is really exciting because increase in scope, because then it means more points of access, or has the potential for more points of access. Another support around later abortion care specifically is that a few years back, the government of Quebec was recognizing that they were that many of the people from their province were accessing later abortion in the United States, and they wanted to do something about it. So they've been working, trying to get abortion past 24 weeks available in their province, and it's happening in some pockets just for folks who live in Quebec and who have Quebec health insurance. And then there is one hospital in Ontario that on a case-by-case basis has been able to provide abortion care past 24 weeks. And it's a kind of a word of mouth and case-by-case, but it's been extremely helpful for people who can't travel to the United States for a variety of reasons. Another great support is something called out-of-country coverage. So every province and territory has some mechanism for coverage if their citizens, people with valid health coverage from their province or territory, needs to get health care elsewhere. And so this also accounts for abortion care. However, British Columbia, Alberta, Saskatchewan, Ontario, and Prince Edward Island, less than half of our provinces and territories, are the ones that are able to process the applications in a timely manner and approve them in a way that folks have been able to access covered abortion care in the United States. So it covers the cost in one of the 6 American facilities that I know of that will take Canadian health insurance, that many people know, not just me. And that's great, but it only covers the cost of the actual procedure and not the supporting costs. So here are some also supports or funding and logistics assistance. So as I mentioned, we have a fund. Action Canada also has a phone line, as well as a fund where people can reach out to either of our organizations, explain their financial need and get some support, whether they're traveling in Canada from a smaller community to another place where the abortion care that they need is available, or if they travel to the United States, or if for whatever reason they're uninsured and need to pay for the cost of a procedure or medication. The Abortion Rights Coalition of Canada has a great list of known facilities and supports, whether they're local groups or national groups. Choice Connect is this great web-based program based out of the Shore Center in Kitchener, a former Planned Parenthood. And you can type in, when was the first day of your last menstrual period, where you're located, and it'll give you information about the nearest abortion provider to your location. And then up until February, when we received funding for 2 years from Health Canada, we used to work a lot with Hope Air, which is a registered charity, and their whole reason to exist is to support people who need to travel for funded medical appointments. And over the last several years, they've been really helpful of helping people who are traveling for abortion care. And then in different parts of the country, there are different doula groups, whether they're specific abortion doula groups or whether they're full spectrum of doula or patient support groups that can often help with some of the on the ground needs. And so these are some great things that exist. So I'm going to talk, probably we've all heard about what's happening in the United States and what's been happening. So I'm just going to talk a little bit about it, but I first just want to acknowledge that I'm not American, I'm not a lawyer, I'm not an expert in this, but I have some information that I would like to share, and not knowing what people's level of knowledge is, I was going to start off with Roe v. Wade, right? So that was a 1973 Supreme Court decision, and it held that, I'm going to read from this so I don't get it wrong because the US system is so different than Canada. So it read that the Due Process Clause in the 14th Amendment of the United States Constitution provides a fundamental right to privacy, and that protects a pregnant person's right to an abortion. The court held that the right to abortion is not absolute and must be balanced against the government's interests in protecting women's health and prenatal life. The court resolved these competing interests by announcing a pregnancy trimester timetable to govern all abortion regulations in the United States. The court also classified the right to an abortion as fundamental which required courts to evaluate challenged abortion laws under the strict scrutiny standard, and that's the most stringent level of judicial review in the United States. So that was 1973. Now, almost 20 years later, we have another landmark decision coming out of something that was introduced in Pennsylvania in 1982. So it's called Planned Parenthood versus Casey. Sometimes people just refer to it as Casey. And this is another decision where the Supreme Court upheld the right to have an abortion as established by the essential holding of Roe, and issued it as its key judgment, the imposition of undue burden standard when evaluating state-imposed restrictions on the right to abortion. So as I mentioned, Pennsylvania introduced the Pennsylvania Abortion Control Act of 1982, and it got challenged all the way to the Supreme Court and resulted in this Casey decision in 1992. And among the provisions were a requirement for a waiting period, so time between somebody asked for an abortion and interacted with their healthcare provider, and then when they could actually get their abortion care. Spousal notice, which I think is obvious, as well as parental consent for minors. Okay, and so that was what was being challenged, and the Supreme Court upheld the essential holding of Roe, which was that the Due Process Clause of the 14th Amendment of the United States protected a woman's right to have an abortion, but they said prior to fetal viability. So they got rid of the trimester framework that they had from Roe in favor of a viability analysis, thereby allowing states to implement abortion restrictions that apply during the first trimester of pregnancy that wouldn't have been allowed under Roe. And so the court overturned the strict scrutiny standard of review of the state's abortion restrictions and replaced it with an undue burden standard. It wasn't ever completely defined, but that what it was saying was that abortion restrictions would be unconstitutional when they were enacted for the purpose or effect of placing a substantial obstacle in the path of a woman or pregnant person seeking an abortion of a non-viable fetus. Again, almost 25 years later, we have another court case related to abortion care that went to the Supreme Court, and it was Whole Woman's Health versus Hellerstedt. And that came out of a restriction that was introduced in Texas. And what the, again, landmark ruling or decision from the Supreme Court was that Texas cannot place restrictions on the delivery of abortion services that create an undue burden for a woman seeking an abortion. And then the very next day, the Supreme Court refused to hear challenges from Wisconsin and Mississippi that were really similar. Fast forward to a month ago, and we have Dobbs versus Jackson Women's Health Organization decision. And this again is another landmark ruling, and that's because it has overturned both Roe and Casey. So the case was about the constitutionality of a 2018 Mississippi law that would have banned abortions after the first 15 weeks of pregnancy. So as I mentioned before, in the original Casey ruling, it was pre-viability, and most people agree that viability is 24 weeks. So 15 weeks is a very long time before viability. So the Women's Health Organization sued the state health officer, and the lower court prevented this law of banning abortions after 14 weeks from going into effect with some injunctions. And they were based on that Planned Parenthood versus Casey viability point. And so what has now happened is that the ruling from a month ago is that the Constitution makes no reference to abortion, and no such right is implicitly protected under any constitutional provision. And that means that both Roe and Casey have been overturned, and that states can now determine whether or not they're going to permit, restrict, or ban abortion in their states. So there were some states that before June 24th, 2020 had laws, old laws on their books, or laws that they had put into their regulation for their states that banned abortion. We called those trigger laws. And as soon as this decision came out on June 24th, those states banned abortion immediately. Other ones have some that are coming into effect. And there are some states that actually saw that this was coming and made sure that they enshrined abortion rights in the constitution of their states. So that's just a really quick overview of kind of what's been happening in the states. Why do we want to know this? Why are people talking about it in Canada? Well, there's a lot of reasons. Some reasons are that people think it could impact what's happening here. I think it's important to talk about it because whenever abortion is in the media, that increased exposure can have some pluses and some minuses. So on the positive side, more people are talking about abortion care, which could, work towards decreasing some of the stigma around it. And people are looking for things that they can do or ways that they can ensure that a very small anti-choice minority doesn't have that kind of power in a country like ours. One of the negative things, and we saw this also with the pandemic when there were restrictions related to the pandemic in different parts of the United States, that some people are concerned that that's happening here in Canada. They're not really sure. I've been asked by many people whether I think we're going to see an influx of American women and pregnant people come to Canada to access abortion care. And I think, although I don't know, because we don't know what's going to happen, but I think that it's pretty unlikely we're going to see a large volume of people. There are so many barriers for people who need to access abortion care. And then we're going to be adding the barriers of needing a passport to travel into our country, navigating a completely different healthcare system, as well as possibly in some cases traveling further than a nearby state that can provide the care that somebody needs. However, I think that we might see some places might see some increase. Maybe some of the bigger cities are easy to access from different points in the United States. There might be friends or family members in some communities in Canada, and if they have to leave their supports at home, they might go somewhere where they have some support. And even a small increase in some parts of the country. So I'm going to use Manitoba as an example, where the abortion clinic there is funded and provides abortion care 2 days a week. Even a small increase for them could have an impact on increased wait times. Another potential impact that we could see in Canada that we're not aware of or we don't know is vigilante laws. And perhaps you haven't heard of them being called that way, but you probably have heard of them because September 1st in 2021, Texas enacted a vigilante law. And what that is a civil means where any individual can sue another individual involved in someone's abortion care. And I think maybe the easiest way for us to understand that could be that somebody accessing abortion care's neighbor finds out that they're accessing abortion care, saw the Uber that came to pick the individual up from their home and take them to the abortion clinic, and then they want to sue the so they want to sue the Uber driver, not the abortion provider, although they could sue all of them. And so one of the questions we're asked is, could that possibly come all the way up to Canada, and could somebody be sued in Canada in that situation? And then I think the other thing that we could potentially be seeing an impact is that we're seeing a more emboldened anti-choice groups and anti-choice activities, including acts of violence in the United States, and just we just don't know whether some of those groups are operating on both sides of the borders or not. But for many anti-choice people, they see what's been happening in the United States as a win, and they feel emboldened to try more things. And I'm not saying that all anti-choice groups or individuals are violent by any stretch, but they also could just be, increasing harassment or trying to introduce troublesome things here in Canada. So I know that many people are feeling like helpless, or I shouldn't say that. I have heard many people tell me that they're feeling helpless and they want to do something. And I think I just wanted to start off a little bit about what we don't need, because I think that some of the things that we're hearing sound at first, thought really great and could be helpful, but maybe when we dig into them a little bit more, we might not think it's the best idea. So one of the things that I've heard from different individuals and some elected officials is that we should introduce a legislation here in Canada to enshrine the right to abortion. I and many other groups don't think that's necessary. As I've said several times, abortion care is healthcare. We have a mechanism for it to be operating here in Canada. And if we were to try to introduce some kind of legislation, it could come with unintended consequences. In the short term, we could see consequences like restrictions on gestation, because we know that there are anti-choice parliamentarians, just like there's all anti-choice people in all elements of life, and there could have to be some concessions made to pass a law. In the longer term, we could see the opportunity for a different government to come and enact some limits. So a law could be a target in that sense. And then also a repealed law could make it, could change the course of the judicial interpretation of the Morgentaler decision. The other thing I don't think we need to do, and I've been asked to talk to a lot of different media sources, and I'm always wondering who else might be involved, because I don't think we need to engage in the idea of a debate or in sides, because I think we recognize that people who are pro-choice make their own decisions for themselves around what they want to do around a pregnancy or what they think they would do around a pregnancy, and they don't presume to make those kinds of decisions for other people. Another thing is we don't need to reinvent the wheel. So we don't need to start new funds. We don't need to start new organizations or patient support groups or community groups where there are already groups that are existing and working well. And then something else I've heard a lot about, which comes from such a lovely place and such well-intentioned, but people who want to take individual action. And I've heard a lot of discussions around anti-networks, and I don't mean anti as in anti-choice or pro-choice. I mean anti as in aunt and uncle, where people want to open their homes for folks who need to travel for abortion care. People want to offer rides. People want to directly get involved. And I guess the caution I have against that is that I recognize it's really well-meaning. And most of the people I've talked to who need to travel for abortion care would like to have the person they want with them, and they'd like to stay in somewhere that is private. And so in someone's home, an individual might feel obliged to tell their story, or we don't know elements of their life. They might not feel safe in those situations. And I've heard individuals wanting to sort of start up some new groups, and I'm always encouraging them to think about like what kind of training are they going to provide, what kind of vetting are they going to provide to make sure that if this is the case, that the people are going to be having the intentions that they say. So as I mentioned, when there's already existing groups, those are great networks to tap into, or they're also great networks to look at the models that already exist and see how they can be replicated elsewhere. So some of the things that we can do is we can get and stay informed, and I hope this is a small help towards that. And also being, as I mentioned before, when we're looking at news or we're reading something or we're looking at the internet, making sure that we are not sharing information that comes from questionable sources. We can try to destigmatize abortion care by talking about it more, whatever our comfort level is, talking about our friends, our families, perhaps our colleagues. And importantly, maybe talk about it with your healthcare provider. I recently got a new healthcare provider, and one of my first questions to him is, do you prescribe medication abortion? If you have the capacity, you could work or volunteer with established groups in sexual and reproductive health and or abortion care specifically. You can donate to abortion funds, and I know not everybody has the means to do that. I know organizations like ours have been looking into whether we can take the donation of air mile points or hotel points, because we're helping people travel and that could deflect some of the expenses. And then I think we can also think about and assess and act within our existing areas of influence. Do we know somebody who is in a position at a medical school who could help drive the need for accurate information around abortion care? Do we know somebody who is involved in healthcare administration and can make sure that abortion care is accessible in that community? Are we a healthcare provider? Can we get involved? I think we have lots of areas of influence. And I think sometimes we think, oh, what can one person do? But I think one person, when you're working together, can do a lot. I feel like I've just given a lot of information. I'm happy for any questions or any reflections. And I've also put up my contact information for folks who would like to get in touch if they think of an idea or a question later on. I will try to respond.
So we do have quite a few questions. Let's see if we can go through the list. A question from Ruth: is there full reciprocity between provinces for provider fees and cost of medical abortion and cost of procedural abortion?
First, hi Ruth, that's a great question, and unfortunately there isn't. So I think as what Ruth is getting to is somebody might be, I'll give it a student as an example, or it might be a student from Ontario who's covered by OHIP and then decides to go to university in British Columbia. Often they can see a physician to get the prescription for medication abortion, but because they don't have health insurance from British Columbia, they would have to be paying for the cost of the procedure out of pocket. And we haven't been able to find a mechanism for payment across the provinces for that. And there are some issues related to that with abortion facilities in community settings as opposed to in hospital settings. So for the most part, people with abortion, accessing abortion care in a different province at a hospital will have everything covered.
Okay, thank you. What body makes the decision about the dates up to when abortion care is available, for example, in Prince Edward Island?
Yeah, so that's a great question. And so as I had sort of alluded to, and I'll say a bit more, is because it's in a hospital setting, often we, all the different groups or departments that are involved need to be involved in that process. That seems to be how it works. So there needs to be people involved in anesthesia who are willing to be involved in abortion care, nursing who are willing to be involved, people who are trained, who've had opportunity to train. So I see PEI as a great example. It's really hard for the clinic in Prince Edward Island to train their own new providers because they don't have a high volume. So they often are needing to travel to a different facility to build up their skills. So training can be an issue for those reasons. So it's not just one person that's involved, it's often a whole community of a hospital. And we know that large organizations often have a lot of bureaucracy, and that can sometimes get in the way. I'm going to stop sharing if that people have my contact information. There we go.
Next question is, access to abortion is seriously limited in Alberta and maybe elsewhere as well, because facilities that object to the procedures are permitted not to provide it. Has there ever been a challenge to this on the basis of the Charter of Rights? And then the second question is similar to that. Has NAF or the Abortion Rights Coalition of Canada considered a court challenge based on the Charter of Rights and Freedoms and the Healthcare Act to force Providence Health in BC to provide abortions? BCCLA would be a strong supporter.
Yeah, so I'll kind of delve into those in a bit. So unfortunately, NAF and NAF Canada, we don't usually get involved in instigating legal challenges. That's just sort of not the focus of our organization, and we don't have the capacity. It would take up too many of our resources, and we wouldn't be able to direct them elsewhere, though sometimes we are involved in a supporting capacity. As far as I know, there hasn't been a challenge based on the charter of access issues in Alberta or other provinces, except there has been a challenge in Ontario. It's not exactly the same, but only the governing body of physicians in Ontario require a physician who is not going to be involved in abortion care to offer an effective referral. And this came up originally around medical assistance in dying, but also is expanded to include abortion care. And there were some groups of physicians that challenged it in Ontario, and they were not successful, and they are made to give an effective referral, meaning actually provide information of somebody they know who will provide the services that folks need. I'm not aware of that happening in other provinces. And then just for folks not in British Columbia, Providence is a faith-based health authority here in British Columbia, and they don't get involved in abortion care, even if they have somebody presenting to the hospital needing some help around abortion care, and there's still fetal activity.
Next question, is there any data that compares abortion accessibility versus other procedures? For example, how many people would have to travel over 100 kilometers for abortion care versus how many people would have to do the same for an MRI, vasectomy, or other procedures? Do we have that data?
Yeah, so I'm aware of research around how far people travel for abortion care. I can't say for other kinds of healthcare, but I think the one thing I can say is that of those different kinds of healthcare that's listed, I think I only identify abortion care as being time sensitive, right? So I do know that we live in a large country, and there's lots of parts of our country, particularly the less populated regions, where healthcare access can be really difficult. And I know we have a family physician shortage all across the country, but abortion care is a very time sensitive kind of healthcare intervention.
Thank you. The next question is about late pregnancy termination. Say if I'm in Saskatchewan and I need to terminate a pregnancy past 24 weeks, what happens?
Yeah, so we've had some great success with the Saskatchewan health insurance covering it. So I've often worked with the clinic in the hospital in Regina, where they're able to complete the required paperwork and have it submitted, and usually within a couple of days it can get approved. And as I mentioned, there are six facilities in the United States that take Canadian health insurance. Their health care system is so different from ours, and many of them just don't take any health insurance. But these six do, and actually there was five, but we were able to work with the sixth one to help them understand how healthcare in Canada is quite different in the United States. And when an insurer says they're going to pay, they are really going to pay, and they're going to pay the right amount in a timely manner. So hopefully somebody who wasn't sure what to do could reach out either to our hotline or could reach out to the access line at Action Canada. we ask that people don't reach out to both because our organizations work extremely closely together, and we don't want an individual have to, tell their story or their circumstances more times that are needed. So if an individual doesn't know where to go, calling those hotlines, we have contacts across the country, and we're often able to direct folks to the process that they need and walk with them through that process and all the different steps that are involved.
Thank you. And we'll take one last question. How does the situation in the States, in the US, affect Canadian women going to the USA for advanced gestation abortion care?
Yeah, that's a great question. And so the 6 abortion facilities, they're in 5 different provinces, 5 different states, because 2 of them are in Washington state. None of them are in states where we're concerned that the legislation is going to change. Where the concern lies is that what we know for the people in the United States, in states where there's all bans or heavy restrictions, many of them aren't going to access abortion care at all, and they're going to be forced to carry their pregnancies to term. But for the ones who are going to be able to access abortion care, they're also going to be accessing it later in their pregnancies because they have now all these financial barriers, because the healthcare system can be more expensive later in a pregnancy, and they have to pay for it, and they have to travel and make all of those arrangements. So one of the big concerns that we have is that there's going to be longer wait times in those facilities that are providing later abortion care. And so even in anticipation of this decision, one of the 6 facilities that we work with who provides later abortion care stops providing abortion care to anybody under 22 weeks because they are already experiencing some waits, and they are longer waits than they felt were acceptable. So because there are other options for 22 weeks and under, they were focusing on where the need was the greatest. So that's a concern. I haven't heard it. I don't know yet. We're still kind of waiting to see. It's only been a month, and there's changes that are happening, every week. More and more restrictions are getting in place. Some of them are being temporarily sometimes the bans are being temporarily halted because they're working on some legal appeals. But right now, we've been able to still support people traveling to the United States.
Great. Well, thank you once again, Jill, for your amazing presentation. Much appreciated. Thanks to our audience for attending. If you do have a moment to share your thoughts about this webinar or suggest a webinar topic or speaker, please fill out our webinar survey. You'll find the link in Zoom's follow-up email. And I would also like to mention that we are supported by membership and donations. So if you are able and would like to become a member or contribute to our educational programs, including the webinar series, you can do so on our website, www.humanistcanada.ca. And we will resume our webinar series in September for the fall series. So please stay tuned for our announcements. And once again, thanks so much, everybody, for joining. And thank you, Jill.
Thank you so much for having me, Anna, and thank you to Humanist Canada and everybody for joining. Goodbye. Good evening.
Bye. Bye. Good evening.